Well, first of all, happy Father's Day, and thank you to everybody who's tuning in lieu of maybe spending a couple extra hours with the kids, or in lieu of maybe helping your kids help your dad or whatever. But we'll do a couple of interesting cases today and then let you go enjoy the rest of your Sunday. So we'll just sort of dive right in. First case is a 33-year-old woman who first entered our health system when she was pregnant, class 3 obesity 3.0. She went ahead, carried the pregnancy to 38 weeks, and was then delivered for gestational hypertension. So after her delivery, we sort of watched and waited for about 6 months, and her proteinuria did improve significantly, but only down to about 3.6 grams of proteinuria. At that time, her creatinine was 0.45 and her albumin was 3.9. So serologies were done and they were negative, including ANA, double-stranded DNA, and the infectious parameters. And so after about 6 months, because of this persistent proteinuria of unclear cause, she was biopsied. Notably, she was not on any RAS blockade because she was breastfeeding. So this is the biopsy that I got. You can see it was actually a pretty ample specimen. Here I have the first core up here, where you can see I have capsule, very little in the way of fibrosis, a nice long core, and it even continues over here. So whatever's going on is not terribly chronic, at least not from a scarring perspective. And if we look at glomeruli, honestly, they look pretty normal for the most part. By light microscopy, you can see here a nice normal, maybe slightly enlarged glomerulus, but fairly normal in appearance, not hypercellular, nice patent capillary lumina, and the adjacent tubules are back to back without any significant inflammation or anything that looks particularly abnormal. On PAS, again, maybe some mild glomerular enlargement, which we might chalk up to her obesity, but back-to-back tubules, and really nothing particularly lesional about these glomeruli at this point. Here we are at corticomedullary junction, and for the pathologists out there, we know that typically in sort of primary FSGS, you're going to get your first scarring at the corticomedullary junction. You can see here we've tagged a portion of an artery, which shows no significant chronic vascular disease. Here we have an intact normocellular glomerulus, and here we do have a globally sclerotic glomerulus, which maybe not entirely normal, but she is 33 years old, so she might be entitled to 1 or 2 globally sclerotic glomeruli. But it wasn't until I looked at the tall blue stain on the tissue that I had submitted for electron microscopy that I got my first helpful lesion. Here you can see a nice, fairly normal glomerulus, but right here, where you have the tubular pole of the glomerulus, you can see some hyalinosis and some adhesion to Bowman's capsule right there at the tubular pole. So this is a pretty classic histologic finding of a glomerular tip lesion. Immunofluorescence was totally negative. We look here at EM, and you can see we have Bowman's capsule here, and then we have a nice GBM here. Endothelial fenestrations and everything are intact. Doesn't look like there was any major endothelial injury while she was pregnant, but what you can appreciate here is diffuse podocyte foot process effacement. I mean, essentially complete podocyte effacement with some added microvillus transformation. We don't see any deposits, and I didn't expect to because the immunofluorescence was negative. Here again, just another shot of the EM showing these GBMs, which overall look fairly normal in architecture. I would say there's maybe a little bit of variation in terms of the thickness here, but really no prominent thinning, no splitting, no lamellation, and really diffuse effacement again. And just one more time with the EM, really nice, fairly normal appearing GBMs, really nicely intact endothelial fenestrations, and diffuse, essentially 100% podocyte foot process effacement. So what I had here histologically was FSGS, glomerular tip lesion variant, fairly mild. I had a total of 43 glomeruli. 3 were globally sclerotic and 1 was a glomerular tip lesion. There was diffuse podocyte foot process effacement. And really histologically, this looks like a pretty classic glomerular tip lesion case. The Columbia group where I trained, obviously, they had put out a paper, a classic paper in 2004, describing this prognostically favorable variant of FSGS that often has presenting features that are more like what we see in minimal change disease and are often much more steroid responsive than some other forms of FSGS. So usually when we see glomerular tip lesion, we feel pretty good about it. So I make this diagnostic comment that, hey, chronicity is mild. She's got tip lesion, which is a favorable variant of disease. So hopefully this one should have a happy ending. So based on this biopsy, we decided to start prednisone for a 2L to see if there was any response. Also in the follow-up plan, and I think this is basically reasonable for anybody at this point who's diagnosed with FSGS, was to consider genetic counseling to assess for potential genetic underpinning of this FSGS. Really didn't have great history on this patient because she really presented already pregnant, and the duration of her proteinuria was really pretty unclear when she came to us. But she did at some point bring in medical records to her nephrologist showing that she'd had dipstick proteinuria and intermittent microscopic hematuria dating back to at least 2018. And then the patient also reported that she had seen as a teen 2 urologists. She's not entirely clear what the details were, but at some point, one of them told her of something very memorable, which is that she had a pinprick hole in her kidney. And this explained everything that was wrong with her kidneys. But we were unable to get any details about exactly what that workup was or what that might have translated into medically. But she was never referred at that point to a nephrologist. So her first encounter with nephrology was basically in her 3rd trimester of pregnancy. So on steroids, her proteinuria actually increased a bit from sort of 3.5 grams where it had been when we started up to the 4.2 to 6.